Hi, my name is Jones Muna. Today, we talk about Respiratory Distress Syndrome, RDS. Hyaline membrane disease. Introduction. Respiratory Distress Syndrome, RDS, is the term given to a cluster of symptoms that indicate severe malfunctioning of the lungs. It is called Infant Respiratory Distress Syndrome, IRDS, if it occurs in infants, and it is commonly seen in premature infants. It develops when the alveoli collapse after expiration and fail to expand during subsequent inhalation. It is treated by administering air and surfactant through a breathing tube until the alveoli begin producing surfactant on their own. Microsoft registered and Carter registered 2009. Normal re-expansion of the alveoli requires a chemical called surfactant, surface active agent, that is made of lecithin and sphingomyelin. In many premature infants, the alveoli are not mature enough to produce this vital substance. Surfactant is in a group of phospholipids and has a tendency to repel water. The lungs are naturally wet and the alveoli walls have a tendency to adhere to each other if no enough surfactant is present. Surfactant reduces alveoli surface tension, opposes the natural tendency of the alveolar tissue to adhere to each other and completely collapse at the end of expiration, thereby keeping the lungs partially patent at all times. During fetal life, it becomes adequate around 36 to 37 weeks of gestation, but its production starts at about 22 weeks. Definitions: RDS is a respiratory condition related to inadequate or inactive surface-active phospholipid compound called surfactant in the alveoli of the neonate's lungs, resulting in difficulties in breathing, hypoxia and lung collapse. It is a respiratory disease of newborns, especially premature infants, caused by lack or inactivity of surfactant, leading to the inability of the lungs to take in oxygen, and is marked by cyanosis and difficult breathing. Microsoft registered and Carter registered 2009. Cause: the absolute cause is lack of surfactant or failure of surfactant to be released from the alveoli. This situation can be precipitated by a number of factors. The normal ratio for lecithin to sphingomyelin should be above 2. If it is less than 1.2, then the baby is at high risk of developing RDS. Interpretation of lecithin-sphingomyelin ratio: a ratio of less than 1.5 to 1. This means that the neonate's lungs are immature. If born now, your baby may have breathing problems. A ratio between 1.5 to 1 and 1.9 to 1. This means that the neonate may be at risk for immature lungs and breathing problems. A ratio of more than 2 to 1. This means that the neonate has mature lungs and is ready for life outside the uterus. Predisposing factors: 1. Prematurity, especially those less than 34 weeks gestation. The lower the gestation age, the higher the risk of developing RDS. Henderson and McDonald, 2005. 2. Infants of diabetic mothers, IDMs, are usually premature and secrete a lot of insulin in response to fetal hyperglycemia. Insulin is antagonistic to surfactant. These babies are usually born prematurely, though they may be big. 3. Asphyxia neonatorum leads to metabolic acidosis, which prevents the release of surfactant. 4. Meconium aspiration may also prevent the release of surfactant from the alveoli. 5. Uncontrolled maternal hyperglycemia may cause fetal hyperglycemia and consequently fetal hyperinsulinism from the fetal pancreas. Insulin is antagonistic to surfactant activation. 6. Acidosis. Maternal hypoglycemia at cellular level may cause anaerobic metabolism, resulting in production of lactate, lowering leading to low pH. This prevents activation of surfactant. 7. Babies born by cesarean section due to lack of stimulation of the respiratory centers. 8. Babies born following antepartum hemorrhage have low oxygen. 9. Cold stress. 10. Cord prolapse and presentation. 11. Tight cord around the neck, strangulation, causes suffocation. 12. Prolonged labor like in CPD. 13. Birth injuries affecting the cerebellum and medulla. Pathophysiology: surfactant deficiency or its ineffectiveness leads to more demand for more respiratory effort to inflate the lungs with each breath, and the neonate quickly becomes exhausted. The alveoli collapse and hypoxemia results. The consequence of alveoli collapse is increased resistance in pulmonary circulation and pulmonary capillary permeability, causing extravasation of fluids leading to pulmonary edema. There is also subsequent leakage of RBCs leaking from the capillaries into the pulmonary spaces, which attract coagulating factors such as fibrin, and coagulation of the exudate sets in to produce a membrane that lines the fluid/blood-filled alveoli and the tracheobronchial tree, hence the name hyaline membrane disease. The resistance in pulmonary circulation causes production of prostaglandins in the walls of the ductus arteriosus that prevents its closure. On the other hand, pulmonary resistance results in increased blood pressure in the right auricle, causing a patent foramen of Valli and ductus arteriosus. This causing right to left shunting of blood, which reduces blood flow to the lungs for oxygenation with resultant hypoxemia and cyanosis. Hypoxia causes lactic acidosis, which further impairs surfactant production and release, and a vicious cycle ensues as metabolism spirals out of control from aerobic to anaerobic with energy overexpenditure due laborious respirations. Signs and symptoms: the initial signs of RDS occur within 4 hours of birth. As said, they are rare in infants over 37 weeks gestation. Crepitation on chest, auscultation due to presence of fluids in the respiratory system, reduced breathe sounds on auscultation, deteriorating OPGAR score, expiratory granting due to laboring during breathing, nasal flaring as a baby tries to increase the amount of air being impaired, sternal retraction as compensatory mechanisms to increase air intake, intercostal or chest recessions, indrawing, progressive tachypnea of 61-100 bpm or more, tachycardia, apnea, edema, cyanosis, central/peripheral, hypothermia, no much energy being produced, poor or no feeding due to fatigue, fatigue due to accumulation of lactic acid in the body. Diagnosis: antenatal, intranatal and postnatal history. Neonatal assessment will reveal signs and symptoms. Auscultation of the chest will depict reduced breathe sounds. Chest X-ray shows a fine ground glass modeling display, a clear line of membrane along the bronchial tree, hyaline membrane disease, blood gas studies, P.O. 2 in PCO2, blood pH, acidosis. Medical management: give oxygen to improve tissue metabolism. Put the neonate on artificial ventilation for assisted breathing. Continuous positive airway pressure or intermittent positive pressure ventilation, Cpap or IPPV. Antibiotic cover to prevent infections, drugs like gentamicin plus fotriaxone plus ampicillin. Surfactant administration via endotracheal tube. Sodium bicarbonate to correct the acidosis. Dextrose 10% for to boost energy levels. Nursing management: continue assessing the baby and OPGAR scoring in Silverman or down score. Airway: clear the airway by suctioning and ventilation to remove secretions and so help with the activation surfactant or its productivity. Resuscitation procedure should be followed if the child is practically distressed. Perform artificial ventilation with bag and mask. If need be, intubation may be done, and if that be the case, IPPV may be the best option for oxygen administration. Use alkyronium bromide to paralyze the respiratory muscles in order to prevent counteraction of pressures if intubation has to be done. The oxygen tubing is then introduced to the bronchial tree through the endotracheal tube. If no need of intubation, and practically the best way to manage apnea is by giving oxygen by Cpap using a musk or hood. It works by pumping in air/O2 at a high pressure to keep the airway open at all times while CO2 is pushed out through the side holes of the musk. Continuous positive airway pressure, Cpap. This method uses pressurized oxygen and machine pumped directly to the lungs without intubating the newborn. The Cpap face musk must cover the mouth and nares. It should form a seal around the 3 openings. Oxygen administration is vital to relieve hypoxia and prevent brain damage. Use electronic oxygen analyzer, pulse oximeter, to measure O2 concentration in inspired air and also blood gas levels. Care should be taken not to cause fires in the neonatal unit when administering oxygen. If Cpap is used, air of about 5 to 10 cubic centimeters is pushed in to effectively splint the airway. Insert a nasal gastric tube and leave it in situ with neonate's head tilted to one side to help in the continuous drainage of the gastric fluids. Distended stomach/abdominal impairs respirations. If IPPV is used, i.e. the neonate is intubated in cases of very low O2 levels of 5 pa, 40 mmHg, or a PCO2 12 pa. This is a state of acidosis and Na2CO32 MEQ/kg is administered. Warmth. This is very cardinal in RDS management because cold stress can worsen the condition. Radiant heaters may be used with water points to humidify the environment. The neonate is admitted in the incubator to help maintain the environment and for ease observations. All the precautions of incubator care must be employed to avoid cold stress, prevent infection and burns. Do not open the incubator unnecessarily to prevent convection currents. Observations. Observations should be done continuously to assess the well-being of the newborn. Assess the heart rate and respiratory rate. Also check the temperatures every 4 hours and ensure that the body temperature falls within 36 C to 37 C. If a skin probe is available and working, use it for continuous monitoring. Incubator temperature should be maintained between 34 C and 35 C for babies weighing 2,000 grams and below, but those weighing 3,000 grams or more, temperature of 26 C to 30 C is acceptable. Perform transcutaneous oxygen monitoring. Monitor urine output, edema, stools for color and consistency and general behavior of the newborn. Feeding. Initially, enteral feeds should not be given to prevent abdominal distension due to the likelihood of paralytic ileus. Enteral feeds introduce microbes into the gut, which is good, but in case of neonates with RDS, immunity is weak that even the supposedly normal flora may result into intestinal inflammation. Parenteral feeds should be strictly given in the first few days. Fluids like 10%, 20% dextrose or half-strength Darrows may be prescribed but not 5%. Gradual introduction of expressed breast milk and weaning from 4 lines should be started depending on the prognosis. Do 4-hourly glucose checkups to monitor glucose levels where there is no automated monitoring gadget. Infection prevention. Observe aseptic techniques. Use sterile instruments for all invasive procedures like suctioning, intravenous insertions and intubation. Wash hands before and after handling the neonate. Restrict visitors to the NICU but give psychological care to parents who may be allowed to enter the NICU sometimes to facilitate bonding. Teach parents basic precautions of the NICU. Remove dirty linen through the back windows of the incubator while clean ones should enter through the clean front window. All dirty procedures should be done through the back windows and the clean/sterile procedures should be done via the front window. Give antibiotics as prescribed to prevent infections. Example, gentamicin and X-Pen or the third-generation antibiotics. Complications. Emphysema, air leaks, pneumothorax, cardiac tamponade, pneumopericardium, hypoglycemia, patent ductus arteriosus, patent foramina valley, hyperbilirubinemia, jaundice, intraventricular bleeding, brain damage, lung atelectasis. Prevention. Prenatal assessment of fetal lung maturity through amniocentesis, delaying of elective cesarean sections, administration of surfactant to the newborn at risk of RDS. It can be synthetic or natural. Give corticosteroids like dexamethasone to mothers who are likely to go into premature labor in order to stimulate surfactant in the lungs. Educate communities about the dangers of early marriages. Thanks for listening and please click the subscribe and share this video to promote this channel.